She got worked up and started on prednisone for this awful pain and vision issues with her eye. I think it's her left one, but the whole workup was unrevealing. I mean, we checked all those esoteric labs that you check for uveitis, all the different infections and that sort of thing. And the only thing that popped out was a herpes simplex titer. Excuse me, zoster titer. But anyway, the herpes virus titer. So she was also started on valacyclovir. So what we have run into for the past year is that anytime we tried to taper her valacyclovir below a gram a day or her prednisone below 20 milligrams a day, her uveitis flares. She has the awful eye pain. She can't see, that sort of thing. So the rest of her labs are pretty straightforward. Random glucose in the office in August was 132. Kidney function is normal. On meds, her SED rate is normal. It's never been terribly elevated. I guess you can scroll down some meter if you would. Cholesterol is reasonable. Triglycerides are reasonable. I mean, her LDL is a little higher than we would like. Liver tests are normal. You can keep scrolling. Hemoglobin's normal. There's a list of her medications. The amlodipine, HCTZ, and pravastatin have all been long-term. All the others, and the sertraline, the others have been started within the past year and a half in an effort to treat the uveitis. She's actually gotten good results from her methotrexate, but we still haven't been able to taper off the other medications. And she's having terrible GI side effects from the methotrexate. I mean, she's sick for 2 days after she takes it. So my question that I kind of wanted just to kick around, I mean, anybody else, I would have started her on metformin probably several months ago. But with the GI side effects she's already having, you know, what else might I use first line to keep her A1C from going up further and not, you know, interfere with the other things we're trying to do? And yes, we're going to keep trying to wean her off the steroid, but I don't know if we're going to succeed. So there you have it.
Thank you so much, Dr. Rexroad. Before we jump into any of the recommendations here, did anyone from the group have any clarifying questions for Dr. Rexroad?
Is she overweight? Can we go back to her body mass index? Is she obese?
Yeah, her BMI is 30.2.
Any other questions from the group? And I'm more than happy to scroll up or down if anyone needs to refer back.
Her weight has actually trended down over the past year. She's lost about 10 pounds in the past year with all this stuff going on.
So a couple things if we're ready to chime in.
Absolutely, yes.
Okay. So a couple things. One is just the prednisone dose in general likely is contributing to this A1C. But her prednisone dose really needs to come down, especially if she's not flaring. I mean, that's really, you're going to end up with a adrenal insufficiency if you don't already have it because of being above physiologic, needs. So that probably needs to be your first, line is that you do slow tapers where she goes down by 2 to 5 milligrams, every 2 weeks, but something that's going to get that prednisone dose a little bit lower so you don't have a second endocrine issue of adrenal insufficiency due to chronic steroid use. Mm-hmm. So I'd work on that. GI side effects, unfortunately, are a very big part of, a lot of the medications. So to say like you're afraid to start it at all, I would be I agree with that, but an A1C of 6.7, you do need to start something. And so could you start metformin? Sure. I mean, you're not going to know. I mean, some people do fine on metformin. I have lots of people that do fine, and sometimes it's just the startup and being a little bit less aggressive with them, using the extended release form. Even if you could get her on 500 twice a day of extended release, that's going to be something. You maybe never get her to the 2000, but to just not start it because you're afraid of her significant GI side effects, she might notice that it is what it is and it's always this way, and it doesn't make it worse. So I think to just assume that it's going to make it worse would maybe not be great, because metformin is a good drug, and it will not induce lows. So as you move your prednisone dose around, you aren't going to have to worry about that. So I probably would try to convince her to start 500 once a day for 2 weeks and see how she does, and then see if you could add a second dose, because then it would then allow you to go into some other drug options that you can use some add-on if you're around 1,000 of metformin. You might want to stay away from the GLP drugs. Those are also GI side effects where it can cause some nausea, some loose stools. We start really low, so maybe not do those, but those are also good drugs that are okay to use by themselves, even if you couldn't start metformin. So then the other classification of drug would be, you have her on HCTZ once a day, you actually might be able to start the SGLT2. So something like the Jardiance or the Farxiga or Invokana. You might actually be able to get rid of the HCTZ or drop that in half, because those drugs actually cause some amount of diuresis, some improvement in kidney function. Doesn't look like she has any cardiovascular disease where you would get that. So, that would be a good, if you couldn't do metformin, you could start that one independently on its own. But you probably, in order to get insurance to pay for it, you might actually have to prove that you started metformin and that they didn't tolerate it. Mm-hmm. So those are, I'd probably do metformin and then add on an SGLT2. If she can't tolerate metformin, try SGLT2s by itself. Now, those are expensive drugs, so depending upon where her insurance is too. She's 61.
Yeah, she has PEIA insurance.
PEIA.
Yeah.
So that's good. That's better than working with sometimes the Medicaid and stuff. Actose is cheap. It's out there. She doesn't have congestive heart failure, but sometimes we see some weight gain with that. And at 61, it's not something you'd want to have on her long term because she's menopausal, risk of some bone disease. But maybe to get her through the short term, it would, maybe be something that would be cheap, easy, once a day pill. Use it for a couple of years until you get the steroid situation, resolved. But just know that that's not something you'd want to keep on there for much more than maybe 3 to 5 years. And then definitely be watching her bones already, and maybe even do a DEXA scan if she hasn't had one done. So I think there's lots of, I don't think there's a right or wrong answer to this question. I think the drugs I offered, as you change the steroid dose, you have no risk of lows with these medications. And therefore, as that changes, you aren't going to really have to worry about that. Mm-hmm. So Dr. Giordano is also on the call, and if she wants to chime in, do you agree, Dr. G?
I think you gave a really great synopsis of options, for metformin extended release for a rising A1C. But, well, first of all, I think it was a great case presentation, and I know it's hard managing these inflammatory conditions, and steroids sometimes are the only option. But my recommendation too is, and I'm not a primary care, I'm not trying to be one, but I think the uveitis, maybe having her see like a rheumatologist or somebody to rule out, like inflammatory conditions, vasculitides, sarcoid, those types of things to help you. Because if you're not able to wean the steroid, as Melissa said, those steroids come, it's a double-edged sword. So they come with right now we can say she has pre-iatrogenic Cushing's because we're giving her such a high dose of steroid. And so I think that of primary importance is figuring out why she has uveitis and getting that treated. And I agree that you guys are doing a great job investigating it, but
well, she actually has seen she's seen a specialized ophthalmologist. She has also seen a rheumatologist.
Oh, I missed that.
It's the rheumatologist who's prescribing the methotrexate and a steroid right now.
Yeah. So I think just working on getting the steroid lower, as Melissa said, would be the really important thing, because that's what's driving up her A1C and will contribute to all the things Melissa said: fractures, poor wound healing, and it'll just, get worse over time with that high of a dose. Yeah, okay. I echo the same things.
Okay.
Thank you.
Thank you all so much for the great recommendations and feedback. Dr. Rexroad, before we jump into the next case that we have here, did you have any other questions you wanted addressed about your case?
I don't think so. Like I said, I just kind of wanted to hear what everybody thought about it, because it's just, she's a complex one and we're trying to weed through what we can weed through. And, she does have a couple of specialists involved. And of course, as always often happens, the primary care doc is in the middle of it.
Yeah, I think that's spoken well. From an endocrine standpoint, we're often, on the sideline actually, and hoping that there's a way the steroid will come down. But from our standpoint, we don't ever drop steroid, even though we recommend getting to the lowest possible dose to control the underlying disease. We typically never touch the steroid in cases like this. We just hope that over time it's able to be reduced or a different agent can be used, and just treat around it like you're doing.
Okay. Thanks, guys.
Awesome. Thank you all so much. And thank you again, Dr. Rexroad, for that great case presentation. We appreciate it. So we have Jen Boyd on too. I know you had to hop on here a little bit after, but we're so happy you could join us. If you're ready, I can pull up your case and I'll just turn things over to you, Jen.
Thanks, Mitra. I'm sorry I missed that case, Dr. Rexroad. And hi, everybody else. My case is a 20-year-old Caucasian male. He has Blue Cross Blue Shield health insurance, and he came to see me last week. I knew him when he was a really little kid, and then I didn't see him for a long time, and then I started taking care of him again about 6 months ago. And he came to see me about gynecomastia, which he said he has had since puberty, not going away. He is obese. I'm sorry I didn't put his BMI on here. I could look it up, but I think it was well, I'm not sure what it was, but he's obese. And he says even when he loses weight, he can still feel, but he says the fatty tissue goes away, but he can still feel breast tissue. He expressed really extreme distress about this. He says not a day goes by that he doesn't think about it. And he was asking me about referring him for surgical treatment. He is a really interesting guy because he's super intelligent, and he always comes in having done a lot of his own research. And I always have to backtrack and say, I'm going to go do my own research because I don't know. And he's fine with that. He reports that he had normal development of, normal adolescent development of his genitalia and pubic hair. I don't remember doing child exams on him during that period of time. By the way, sorry I don't have camera today. I can't figure that out. He started seeing me actually last spring with concerns about diffuse hair loss, and I started him on finasteride, which has really helped his hair loss. He said that the gynecomastia was present prior to that and did not seem to worsen that. In the initial workup, he I diagnosed him with hypothyroidism based on an elevated TSH. I started him on levothyroxine, 25 micrograms, and his TSH is normal. I did refer him to an endocrinologist, a local endocrinologist at that time. And one reason I referred him was that he was convinced that he needed some supplemental testosterone. I can't remember why. I think energy, maybe he was tired or something. That's what it was. He was tired. And I did testosterone levels and they were normal. And I said, I am not going to prescribe it. Well, I couldn't prescribe him testosterone anyway. And I asked him if he wanted to see an endocrinologist, which he did. And probably that physician might have been somewhat annoyed at the referral because, it was basically I think a referral to communicate with somebody. And apparently the communication did not go well because he felt as though he was blown off. So he was unhappy with that experience. On his recent, so his comorbidities are obesity, hypothyroid, and at his recent exam, I did palpate this breast tissue. I didn't measure it. I didn't know if that was, later I read about it and I wondered, oh gosh, maybe I should have measured it. But it was about 2 to 3 centimeters of palpable tissue below the areola. And if you need me to get his BMI, I can't. I apologize, I put that in here. And labs are here, as you can see. In January, his TSH was 6.5, T4 was normal, TSH after a month of levothyroxine was 1.67. I didn't include this in my questions, but apparently the endocrinologist wanted to do other additional labs, which he refused. I'm assuming maybe autoantibodies, and so I guess I'd like to know, should I have done that? At the time in January, CBC, CMP, FSH, LH, and testosterone were normal. There are his medications. So the case really is about this gynecomastia, and what is the recommended workup for this guy? From what I've read, it came on in adolescence but hasn't resolved. It's distressing to him. And from what I've read, surgery isn't the only option, but I'd like some recommendations on, are there other things I need to obtain in the evaluation, and what can I offer him as far as options for treatment? I think that's everything.
Thank you so much, Jen, as always. Before we jump into the recommendations and feedback, any questions from the group for Jen? And any recommendations or feedback from anyone, feel free to unmute or chat in. I'm more than happy to pull up the case again as well to show the comments and questions that Jen had here. So
are we ready?
yes, ma'am, anytime you're ready.
Okay. So a couple of things here is, most of the time with, you kind of want to reassure the patient of not having like anything terrible. So the fact that this has been persisting since puberty is most likely a puberty gynecomastia that hasn't resolved. He's only 20, and not uncommon for this to persist into time, and a few things likely are causing it to not go away very quickly, even though he is through puberty, but he's still young, and I think it's not uncommon that this is still persisting over time for him. So the fact that it's not rapid, you can reassure him likely not tumorish, but and more likely related to that. Asymmetry also. So did you say it was both breasts that are this way?
It was bilateral. It was slightly bigger on one side. I think on the right, slightly bigger, but it was definitely bilateral.
Okay. So, asymmetry sometimes is a little bit more concerning than bilateral. So that's another reassuring part of this. And you said you did his exam, so that measuring the size is an important aspect, but also making sure that you're doing the exam and truly feeling that nodular, because if you don't feel that fatty, that nodular part, and you're just feeling fat and you're not doing that squeeze, if you actually have access to up to date, it will give you a how to properly do the examination for him, and making sure that there is a true nodule underneath of it. So I'm not questioning your exam, just making sure that everyone kind of knows that, because that's an important part, because if you don't have that nodule, then it's just breast tissue and you don't have gynecomastia. Okay, so making sure that that's the case. And then when you do have it, over 4 centimeters is another important number to kind of remember, where we would actually do a mammogram on that. So the other thing is for him is to also do that testicular exam. So you had commented that he had the hair and that type of thing, but actually looking at his testes and phallus and making sure all that is of normal size and no lumps and bumps or uneven or asymmetry down there, so that you're ruling out some other types of problematic things that could also be contributing to gynecomastia, such as maybe even Klinefelter's or some of the germ cell stuff that goes on, Sertoli's tumors and those types of things. So making sure that that's also the case. So a couple of things too, also, I guess, to kind of just enlighten you, and that the obesity, so the fact that it hasn't gone away is probably because of it's still persisting. And a couple of things that is causing that to still persist is one, his obesity, and his testosterone is being aromatized by the fatty adipose tissue, and in turn that is increasing his estrogen numbers or stores. And when you have that happen, then you have this unequal ratio, and in turn the gynecomastia will persist. So that could be one thing. I think the one part we're actually missing is just making sure, so a lot of gynecomastia is this pubertal that persists in general, but then the other things are meds, and alcohol is another significant portion for gynecomastia. And so alcohol will cause it, marijuana, heroin, opiates. So making sure, I mean, you said he's a very intelligent man, but we all can get duped by what they do as far as that. So a good history as far as any type of substance use that will also cause that to persist and not go away. The finasteride, you know, you said it was something that also, you know, he didn't notice it get any worse. And it truly is most of the time the bigger milligrams, the 5 milligram dose, and he's only on the 1. But it also is going to likely cause some persistence. So it's not going to make it worse, but it's definitely not going to help it get better. So keeping him on the lowest dose and making him realize that that's just not helping the process. As far as that, that would be another aspect there. So those are like the big things. I think he needs a couple more labs. Also, once you know he has gynecomastia, hyperthyroidism is, so that's ruled out because you're on, put him on a little bit of levothyroxine. That's a really baby dose and got some pretty big numbers. So if he feels better on it, I think it's fine. Sure, if you want to know, does he have thyroid peroxidase antibodies, which potentially could be contributing to his hypothyroidism, I would get it. 25 milligrams is super low. You don't want to deem someone to levothyroxine for the rest of his life if he truly doesn't need it. And was, you know, you did TSH and it was 6.5, but where was your repeat, kind of, you know, to make sure that it doesn't improve. I'm not sure where the ranges are there. Sometimes they're as low as 4, sometimes they're 5.5. his upper normal limits, depending on your lab. So that's where it might help you, because you put him on 25. That's not very much. That I wouldn't even suspect that your TSH would drop that much. But it might have dropped just because you caught a bad lab and he went through some thyroiditis or something like that. And it really would have resolved on its own if you had just done maybe a repeat. So getting the thyroid peroxidase antibody might help you in potentially getting them off that in time. So kind of delving over to something else. But again, 25 mics isn't making him hyperthyroid. So if he feels better, sometimes it's perfectly fine to just make sure you're monitoring it. I just don't like to put meds on young people when you don't need to. But as far as gynecomastia, it's normally hyperthyroidism. So that's why you're checking the T3 and the T4, or excuse me, the TSH and the T4 level. You said his testosterone was normal and his LH is normal. I would want to make sure was those done at 8 o'clock in the morning? Was he fasting with not having a greasy meal? And then what is the LH and FSH? As endocrine people, normal is good, but sometimes normal can be inappropriate. So it is kind of important to know, was it, on the low normal LH, FSH numbers, so that there wasn't any inappropriateness going on there. And then I would also get a prolactin with gynecomastia to make sure that he may say he's not lactating or anything like that, but I would get a prolactin level. So that was one thing that was kind of also needed. And then also an HCG level. And again, that's the whole germ cells, Sertoli cells type of thing, so that you're rolling out any other diagnosis that you're not seeing, but it's causing gynecomastia. So prolactin, HCG, if you had an LH, FSH there at 8 o'clock in the morning with a testo number, that could help me on that. And again, any one-time testo numbers, if they even are off, you need to repeat those and make sure that they're repeated before you do any type of treatment. So those are
super helpful.
okay. Good.
Yeah, I can give you a couple of things right now. It was morning, he was fasting.
Okay.
And his testosterone total was 424. Our lower limit of normal is 264. His free testosterone was 16.1. They didn't give me a reference range on that. I don't know if there is one. I did not repeat his TSH, and that's a good point. I mean, until I had treated him. FSH and LH were, I'm pulling that up. Let's see here. 1 second. It looks like they were, FSH was 3.1, which was, lower limit of normal is 1.5, upper limit is 12.4. LH was square in the middle of the reference range at 5.1.
So also being obese, know that even if so it's very also reassuring, because, just on his fatigue side, to kind of also prove to him, hey, you don't need testosterone, is that his total is normal and he's obese. And obesity can sometimes also make your total testosterone. It has to do with sex binding globulin. But sometimes it can look a little bit low, and then we like to see that the free is normal. And so that's, also reassuring to him. If he didn't get, good feeling from the endocrinologist, I would just let him know that the fatigue is not from that. And again, his testosterone is normal. So then, we don't have to worry about some of that Klinefelter things that I was talking about and other secondary reasons that he could be having gynecomastia. My opinion is that he has some potential contributing factors due to obesity and his medications, and look into to his alcohol use. And I just think it's puberty that has not resolved yet. And many times for boys, you know, they're still pubescent, growing, changing until they're easily 21, 22 years old. So it definitely is late for him, but his obesity is causing some aromatization of estrogen, and that's causing it to hang on longer.
That's helpful. And just back to physical exam, he, you know, I didn't push him. He really was uncomfortable with the genital exam, but I can talk to him about that again. And I only saw that 4 centimeters after he left the office, and I did go to up to date. But when I was palpating, it most definitely was, you know, nodular breast tissue. Because, you know, I did a careful exam, and he wanted me to do a careful exam because he, you know, he knew that, you know, he said, this over here, this is fat, you know, he sort of grabbed his armpit, you know, and then he said, feel this. And so, and then I didn't precisely measure it, but I, you know, when you're used to feeling things, you know, I could tell how many fingers it was. So it was less than 4 centimeters. And the 4 centimeters, again, remind me that would be more worrisome for a syndrome.
Just know to do a mammogram.
Okay, gotcha. Okay.
Do a mammogram and make sure, as far as, you know, breast cancer.
Gotcha. Okay. Yeah, it's really helpful. Thank you very much. I feel like I could go back to him with a plan. And so it sounds like at this point, don't refer for surgery. That sounds like it would be extreme. Encourage him to wait a couple of years and continue on his weight loss, or return to his weight loss and see what.
Yeah, and then just know that the meds are also, you know, gonna make it slower for him, and, you know, make sure he's not, you know, doing any
alcohol
abuse. Yeah.
Awesome. Hey, thanks a lot. Really helpful.
Okay.
Thank you so much, Jen, for that case presentation. Were there any other comments or feedback for Jen and her case before we move on to the didactic?
I just had one quick comment. That was a great case, and Melissa, I think that was great recommendations. Sometimes in clinic, if I'm unsure, if a patient presents that it has obesity and I'm unsure if it's truly breast tissue or not, I will do a mammogram. So I don't always reserve the mammogram for patients who are have the red flags like Melissa were mentioning. And the red flags are breast tissue greater than 4 centimeters, or like unilateral breast tissue, any breast discharge, sudden onset of the tissue, or severe tenderness. Those are kind of the red flags, and also associated lymphadenopathy. So, you know, armpit, within their armpit lymph nodes or neck. Those are the red flags for a mammogram, but sometimes I just do it to define, is there breast tissue or is there not? Because it is tough to do exams sometimes on obese men. So I think that can be helpful. The other thing I wanted to mention is I've gotten burned many times, like Melissa said, if you ask, oh, are you taking, you know, alcohol or drugs? But herbal supplements too are culprit for that. I think generally speaking, his labs are really reassuring because his testo is normal. And if he did have a tumor, that like a germ cell or Sertoli tumor, an adrenal tumor, you would expect his LH to be suppressed from high levels of, you know, estrogen, estradiol, or testo. So I think the fact that his LH, you said, was in the mid-normal range is also a good finding. And a good finding too is that it's been bilateral and it's been since puberty. Sudden onset things are really the red flag.
Okay, very helpful, both of you. Thank you a lot. It's so much better to hear it from than to read it and up to date, you know. This is really, I cannot thank you enough for your expertise.
Thank you all so much for the feedback, and thank you again to both Jennifer and Dr. Rexford for the case presentations. We appreciate it. All right, so we'll turn things over to Melissa. I'll pull up your didactic for you. Just let me know when you'd like me to advance to the next slide.
Okay. So the topic was pituitary. I think it was pretty generic, so I chose the incidentalomas, which is most likely what a lot of primary care providers potentially can run into. Next slide. So we're going to talk about what are pituitary incidentalomas. I'll give you some images of the sella. talk about the hormonal evaluation that we should do when we find these pituitary masses, and then a couple of drugs, management, surgery options that we'll have. Next slide. So this one's pretty obvious here. Some of them are definitely not this big, but this is a pituitary incidentaloma. Next slide. So what are they? They are usually found, pituitary masses, through CT scans. They had something else done because they were having headaches or, I don't know, neck pain, and they do brain MRIs. So usually through some other type of imaging, they'll end up finding some type of lump or bump on the pituitary. So that's how incidentalomas, it wasn't the initial reason. It wasn't like you were looking for some pituitary dysfunction, but that you did some other imaging and it found it. Next slide. No signs or symptoms of the issue of pituitary issues, but it was found for some other reason. You can give the whole slides. I forgot that it did this. Oops. Okay. So they are not uncommon. So they are actually more common than you would actually potentially even guess. Somewhere between 5 and 35% of masses are discovered in MRIs and CT scans. Next slide. The best way to look at the pituitary is through an MRI. And depending upon your institutions, ours is always called MRI cellas, with or without contrast. And we do with contrast when possible. Other people will have brain MRIs, but then you kind of write in there, you need a pituitary protocol. Because if you just do a brain MRI, it's not going to hone in and give you the slices that you need to be able to see some of these tiny pituitary masses. Next slide. So this is not that we don't use radiology reports as well, but when we get them here in our clinic, we just kind of pull up two views that are most important. And it is the coronal and sagittal views. And these give us these tiny little cuts through the pituitary so that we're able to see it. The next slide gives, I think, an image. So when you're looking, you'll go, and if you look on all your images, there'll be a section that's labeled coronal. And this is more Dr. Perini teaching me how to do this. And this is looking for those 4 holes there for the carotids, the internal carotids. And you can see them marked there on the left with those lines. And then the pituitary, the next image, I think, gives us some of the better. Yep, there we go. So then you can see once you find those 4 holes, you're looking basically in between those for the optic chiasm. Pituitary masses, very important to know, is this pituitary mass big enough to be impinging or butting up against the optic chiasm? And that can cause some of your visual disturbances. Then you can see the little stalk there, and then the pituitary there on the bottom as it's marked. And that's at the bottom 2 holes is where you're looking for the pituitary mass. Next slide. Sagittal views, this is my favorite view, and you can see there it does look like a seahorse with the little bit of the beak. And so when you're scrolling through the sagittal sections, you kind of bring it to where you see that seahorse looking picture, and then you can look for the pituitary, which is basically hanging off the beak. Next picture. And there you can see where the optic chiasm is kind of that white line across. The infundibulum is the kind of the beak kind of hanging down, and then the little baby belly there underneath is the pituitary. Next slide. So this MRI cella does help differentiate between paracellular masses, cellular masses, and pituitary lesions. So, and we're of course just talking about the pituitary lesions. Next slide. And this is the most common of all of those cellular masses that you see there. Almost 90% of them are pituitary adenomas, either micro or macro. I think that says in the next slide. And then these are the other ones, types of malignant tumors that can be coming, gliomas, also a lot of benign. We see this too, some rat cleft cyst type of, and craniopharyngiomas. Sometimes those can get kind of big and still cause some problems. But there's also infectious and inflammatory processes that can happen to the pituitary, as well as just sometimes hyperplasia and vascular lesions. So a lot on your differential that we're not going into today, just the incidentalomas. Next slide. So that was, again, that picture, and you can see how big that basically you don't even really see the beak at all. And that's a very large pituitary mass. Next slide. So I just said microadenomas and macroadenomas, and it is important to know the size. So when you're looking at your reports, not that you'll determine or read the size, but less than 1 centimeter or greater than or equal to 1 centimeter. Less than 1 centimeter are the micro, and there is a different amount of management that happens with microadenomas versus macro. Next slide. And that's what I just had said. So sometimes they're super small, and these are micros, and you can see that one. Next slide, it's going to give you a macro. And then you can just see how that right smack in the center between the two holes is a very large one, and root could be huge. And then the next one is funny, but not funny. But that entire white section there is even a larger one. So you can't even, that's just huge. Next one. So you're going to ask yourself questions when you find these incidentalomas is what do they look like? And I already discussed how do they, how big are they? Are they greater than or less than 1 centimeter? And is it causing any abutment up against the optic chiasm? And then once you determine those things, then you need to say, is it doing anything? Is it producing any excessive hormone or so big that it's squishing and not allowing the access, the pituitary axis to get to the thyroid, the adrenals, or whatever? So is it a clinical problem? Next slide. So here are some images that we talk about as far as how you will monitor it. Most of the time you guys see these pituitary adenomas and you send them to us, but these imaging just for your own understanding of when we would do them at the different time frames depending upon the size. So over 1 centimeter, the big one is you repeat it in 6 months and again at 12 months. And then there is a process of monitoring it every 1 to 2 years after that. And these are endocrine guidelines. Next slide. Visual field testing. So this is so we don't have to go into the MRI machine all the time. There's a lot of visual field testing that gets done. Definitely if you have any abutment up to the optic chiasm, and pretty much I have patients do this all the time whenever they have a known pituitary adenoma. And these are done by sometimes optometrists, but you need to make sure they have the equipment to do visual field testing. But otherwise ophthalmologists, your medical doctors will be the ones that do these. Many times visual field testings are done in place of MRIs once you get them extended out. So say they don't need one for 2 years, on the year marker, you'll get visual field testing. If they don't need one for a year, then you'll have them do visual field testing in 6 months, and then they'll do the MRI in a year. So it's, so they don't need continual MRIs, but to be watching that optic chiasm. Next slide. So again, what are, not only what does it look like, but what is it doing? And I had said about overproducing hormones or pushing on it so much that the axis can't get a normal or an adequate amount of hormone. Next slide. So everyone also will get some amount of a hormonal workup, and this is also depends upon the size on how much of a hormonal workup. There's a minimalist approach and then a maximalist approach. Next slide. So prolactin, FSH, or excuse me, prolactin, TSH, and free T4 and IGF-1 pretty much tend to be my minimalist when you have a adenoma that's less than 1 centimeter, but you you also have to, continue with your basic assessment and find out if other parts or other axes could be impinged as far as, weight gain, dizziness, lightheadedness, blood pressure issues. You might even at a minimalist approach still decide to do an 8 a.m. cortisol because they're like, well, I'm always lightheaded and I have no energy and I feel this way. So, or you get the complete opposite. I'm gaining weight and I can't lose any, and I've gained 60 pounds in the past 6 months. So then you would want to do the midnight salivary cortisol. So these are all the labs. Prolactin is definitely the one that you want most common because that is the most common adenoma from incidental adenomas. So prolactin levels, what is it? Is it overproducing prolactin? LH-FSH with 8 AM testosterone, and then obviously females will be estrogen. And those labs will tell us, is it too much, overproducing tumor, or is it squishing and not allowing those hormones to basically get out? Same thing for TSH and free T4. Again, more commonly is probably seen as an underproducing squishing, but you could end up with TSHoma or something like that that's causing an overproduction. So IGF-1 is for acromegaly. That one needs to be done annually. And the reason why that one's done all the time is because those types of acromegalic features take a long time to show their face. And usually by the time you actually notice it, an increasing hand size, forehead, jaw, those types of features, they've had a long time of excessive growth hormone. So, and you don't check growth hormone, you check the IGF-1 because that's the one that is more stable and less fluctuating. Next slide. So I already kind of talked about this, but that's the whole minimalist approach, is IGF-1 and prolactin. Again, I always do a lot of thyroid in there, but by guidelines, those are the two. If you have less than 1 centimeter and they have no concerning symptoms. This is the IGF-1 I already talked to you about, is that by the time you have symptoms, they're pretty big and out of whack. And then the prolactin is the most common functioning of a pituitary tumor, and it's treated with pills. So very unlikely to ever have surgery due to a prolactinoma. Next slide. So non-functioning tumors, that means you test all those hormones and everything is normal. There's no surgery. We reassess labs again in 6 months. We reassess labs again another 6 months from there, and then it can be annually after that. And if it also proves to be stable, then you do not need to continue with monitoring. MRI at 1 year, then every 1 to 2 years for 3 times, and then less often, about once every 5 years from there. So they are a little bit taxing as far as monitoring is concerned, even when they're non-functioning. But this is the recommendations. Next slide. Did I put 2 slides in there? So that's the same one. I just kind of put this in there just to kind of say, has anyone had surgery yet? And the answer to that question is no. Any size tumor that is non-functional, not suppressing, no symptoms, and not abutting against the optic chiasm, they are not going to need surgery. Next slide. Everyone, though, will get a hormonal workup. Remember, I said to evaluate for hyper and hypoactive hypofunctioning. I just kind of gave some numbers here to show you that there's some of these labs that you would be concerned for. Now there's an LH and an FSH that's super low. That would be something that's squishing and likely then ending up with a low testosterone level. So, and then the prolactin level is super high. Next slide. And there is some abutting on the optic chiasms, so that's also concerning. Next slide. So we do visual field testing because the MRI shows that it's impinging, and we do see the visual field is showing some deficits. Next slide. Does that patient that I just talked to you about, does it go to the OR? And the answer to that is no. And why do they not go to the OR? Because we're going to treat them medically. Next slide. These are the most common drugs, dopamine agonists, both bromocriptine and cabergoline. As drugs, usually we want to start at the lowest possible dose and continue adjusting doses, usually once every 4 weeks. We can do it a little bit faster if necessary. And when you make the adjustments to decreasing the prolactin levels. Cabergoline is used more often. Bromocriptine is the older drug. Next slide. I'm not going to go through all of these, but cabergoline again is the most common. The reason we use it more often is less side effects. People tend to tolerate it pretty well, but on the startup of these drugs, sometimes we do see some headache and nausea and dizziness. And this drug is dosed twice a week. And then you do an increasing, as I had talked about. Has a longer half-life, and that's why you actually only have to dose it twice a week. Next slide. Bromocriptine, we do use these. I use the word B for bromo and baby. So this is the approved drug if you would have to use medication during pregnancy, but most often not, and that's a whole nother topic. But bromocriptine is a daily dosed medication, sometimes a little bit more side effects, but the same exact ones. Again, I use cabergoline almost on all my patients, and then bromocriptine is my backup if they don't tolerate cabergoline. But both of them work very well. Next slide. So MRI at 6 months and then 12 months, and that's for any size that you initially find incidentally, and then annually. If you would have, and this is more, I'm sorry, for the prolactin, and if your prolactin does not improve on those two drugs, you actually would then repeat the MRI sooner. So a straight up prolactinoma, you find the high prolactin level, MRI in 6 months, MRI again in 12 months, and then any time in between would be due to a prolactin level that's not moving on max dosing. Next slide. So pills again is first line, and surgery is only if they're intolerant to pills or in rare cases resistant prolactinomas. I don't think I've ever had one. I thought I did, but really it was non-compliance. So when I told her she was going to have to go to surgery, miraculously the pills started to work. Next slide. What about functioning tumors that are not prolactin? Those are the ones that actually would get sent to surgery, regardless of size. Okay, so those are the ones like acromalic, and you have a high IGF-1, those are going to go to surgery. There are medications also that we can start in time for surgery, but again, we're not going into all of those types of issues. But there are some that we would send to surgery regardless of sizes, but prolactinomas do not get to surgery unless resistant. Next slide. This is mostly repeat and mostly for you to continue, but non-functioning tumors pushing up and causing problems on it to the optic chiasm would get sent to surgery as well. Next slide. Tumor is not producing any hormone, but it's squishing out the other usual tumors. Sometimes if they're not causing just that problem, but not causing an optic chiasm problem, then sometimes we'll just replace the missing hormones. So say it's squishing so much that the thyroid isn't functioning well, then we put you on thyroid hormone. Sometimes cortisol, hydrocortisone if it's squishing out to that level. And then surgery sometimes is then that's discussed, but you always want to do the replacement because these surgeries are not something that happen in a day or two. So you'll end up doing the replacement hormones until they can get to surgery. Next slide. Next slide. So everyone again gets the hormonal evaluation. It's all those labs: prolactin, IGF-1, TSH, free T4, your androgen hormones, LH, FSH. I think that's it. And everybody will get your imaging. Watchful waiting, that's for prolactinomas in general. You need to give those time to work, and you treat with surgery and remove it only when medications fail. Next slide. Remember, most don't need surgery in general. And if they are non-functioning, non-suppressive, meaning not pushing, preventing the access, and there's no aptochiasm issue, you will just watch and wait those. Next slide. If it is making prolactin, you want to use pills, and those are the bromocriptine and the cabergoline. And as long as those numbers go down, you can reassure yourself that as the numbers decrease, the tumor size is also decreasing. And you'll repeat that imaging in 6 months and you'll see that it has decreased. Next slide. Aptochiasm. This is an endocrine thing where you always get the visual field, but you will also be referring to surgery if there's involvement, impingement. Next slide. So visual fields, abnormalities, as long as it's not a prolactinoma, then that's when they would go to surgery, as long as it's not a prolactinoma. Some other surgeries that sometimes need is pituitary apoplexy, and that's when you have a bleed into it. And then that hypersecretion, this is just review. So overproducing thyroid, growth hormone, those type of hypersecretions, we would want to, Cushing's, those types of things, we would want to do surgery. Next slide. So surgery suggested for these types of things. Unrelenting headaches, that's another big one, and branch in that. Next slide. This is one other part I thought I should bring up in the incidentalomas, because many times we hear this empty cella, so people think there's no pituitary, but that's not the case. What is an empty cella? Next slide. It's basically that the pituitary is just kind of squished to the one side. So that's all it is. But you will still have to assess for all those hormonal deficits that's possible. And many times there are deficits, but many times there's not. And I really agree with this 50-50 comment. Sometimes there is and sometimes there isn't. So it's not that it's not there. It's just smushed so much that we can't see it. Next slide. We are out of time, so I won't overly summarize, besides to just realize that hypofunctioning you want to replace. Hyperfunctioning, we will do surgeries unless it's a prolactinoma, then we just want to do pills. Next slide.